Welcome to PRISM Rounds, the audio journal club, where we break down one study at a time for ICU, pulmonary, and critical care clinicians and trainees. Think of this as teaching rounds you can take on the go.
Minus the pager going off every 3 minutes.
Low bar, but we'll take it. Today's septic shock, endotoxin, and whether we finally have something disease-specific to offer.
Yeah, and I mean, the stakes here really can't be overstated. We're talking about roughly 500,000 U.S. cases every single year.
They're massive.
Right, and the mortality rate is still hovering near 40%.
Which is terrifying when you actually think about it.
Yeah.
If this were, a novel virus with a 40% kill rate, borders would close tomorrow.
Oh, entirely. The global economy would shut down. But because it's septic shock, it's just a regular Tuesday in the ICU.
Exactly. And when you walk into the intensive care unit this morning, and you're looking at a patient crashing right in front of you, the terrifying reality is that we have zero therapies specifically designed to cure it. Like, none.
Right. I mean, we push fluids, we give broad-spectrum antibiotics, and just hope we guess the right bug.
Yeah, we pump in synthetic adrenaline just to artificially clamp down their blood vessels. We're essentially propping up a burning building and crossing our fingers that their immune system eventually puts out the fire.
It's a brutal way to practice medicine. We've been trapped in this sort of dark age where we treat this vastly complicated syndrome as if it's just one uniform disease.
Right, the whole one-size-fits-all approach.
Exactly. It's like diagnosing someone with chest pain and giving every single patient the exact same pill, whether it's a massive heart attack, a pulmonary embolism, or, just terrible acid reflux.
Yeah, we group it all under sepsis, but the biology killing the patient in bed one could be entirely different from the patient in bed two. And I guess that's why every major clinical trial trying to find that magic bullet has failed.
Well, yeah. Which brings us to this whole concept of sepsis endotypes.
Okay, let's break that down.
So an endotype is basically a distinct pathobiological state. It's the specific molecular mechanism, the microscopic cascade that's driving the illness in that specific patient.
So if we isolate the exact mechanism, we can actually target it.
Yeah.
That's what the Tigris trial did, right? They focused on one specific, highly lethal endotype.
Yeah, endotoxic septic shock.
Okay, let's physically picture what's happening inside the patient here. Endotoxin, or biologically lipopolysaccharide, it's a structural part of the outer cell wall of gram-negative bacteria.
Right, E. coli, Klebsiella, Pseudomonas, the notorious ones.
Yeah, those guys. And as they replicate, or more likely, as they get violently ruptured by our own antibiotics, they literally shatter. And they shed this lipopolysaccharide directly into the bloodstream.
And our immune system has evolved over millions of years to recognize that exact molecule as, the ultimate biological red alert.
It triggers the cytokine storm.
Exactly. It binds to toll-like receptor 4 on our macrophages, and it acts like a key turning the ignition on a nuclear weapon. It triggers this massive release of inflammatory cytokines.
And we always throw around the term cytokine storm, but we should explain how that actually kills you.
Oh, sure. So cytokines are signaling proteins, things like tumor necrosis, factor alpha, interleukin-6. And in this state, they act like microscopic drill bits attacking the patient's own blood vessels.
Right, because normally your endothelial cells are zipped tightly together. They act like a closed pipe, so you can pump pressurized blood to your brain and kidneys.
But the cytokines force those tight junctions to pull apart. They turn a closed pipe into essentially a porous soaker hose. The plasma literally leaks out of the vascular space.
So your blood pressure just bottoms out because there's no fluid left in the pipes.
Right. It floods the tissues. It floods the tiny air sacs in the lungs, drowning the patient from the inside. Acute respiratory distress syndrome. The kidney shut down because the perfusion pressure drops to 0.
It's just complete multi-organ failure. But here's the truly sinister part of this endotoxic endotype. You don't even need a primary gram-negative infection to die from it.
Yeah, this is fascinating. You could come in with a gram-positive strep pneumonia or even a severe viral infection and still die of massive endotoxemia.
Which sounds completely counterintuitive. How does that happen?
You have to look at the gut. Our gastrointestinal tract is basically a massive walled-off reservoir containing trillions of gram-negative bacteria.
Trillions.
Right, and they live there harmlessly because the mucosal lining acts as an impenetrable fortress wall. But in severe shock, that fortress is abandoned.
Because the body is shunting blood to save the brain and heart.
Exactly. Blood pressure drops, the sympathetic nervous system kicks in, and it ruthlessly steals blood away from the gut. The intestinal tissue becomes profoundly ischemic. It literally starves for oxygen.
And as those cells suffocate, the tight junctions break down.
The wall crumbles, and billions of gram-negative bacteria, along with their endotoxin, just leak out into the systemic bloodstream.
So the gut basically turns traitor. It acts like an internal biological weapon, dumping pure fuel on the fire, completely independent of how the sepsis originally started.
Right, so if we know this endotoxin molecule is the match igniting the gasoline, we can't just keep pouring IV fluids into the patient. We have to physically extract the match.
But you can't just blindly filter someone's blood without knowing if endotoxin is actually the problem.
Right, which is where the diagnostic side finally catches up. The Tigris trial used the Endotoxin Activity Assay, or the EAA.
So endotoxin activity assay, then we'll just say EAA from here on out.
Perfect. It's the only FDA-cleared rapid diagnostic test that can quantify the functional activity of circulating endotoxin in whole blood.
And they didn't just enroll anyone with a high EAA level, did they? They established a really specific treatable range.
They did. They only enrolled patients with an EAA level greater than or equal to 0.60 and strictly less than 0.89.
Okay, the lower boundary makes sense to me. Below 0.60, the endotoxin burden just isn't high enough to be the primary driver of the shock.
Exactly. You'd be exposing them to the massive risks of a blood filter for absolutely no biological benefit.
But it's that upper limit that I think trips people up. Excluding patients with an EAA of 0.90 or higher, intuitively, you'd think the sickest patients with the most toxin would need the filter the most.
Yeah, you would think that, but you have to look at the actual mathematics of the physical device. The EAA test isn't perfectly linear forever. Once it hits 0.90, the assay itself becomes saturated.
It just maxes out.
Right. A level of 0.90 correlates to an endotoxin burden in the patient's body that exceeds 30 micrograms.
30 micrograms is a biological breaking point because the specific cartridge they use has a strict maximum removal capacity of what, roughly 12 micrograms?
Exactly 12 micrograms.
Like a basement flood. If a pipe bursts in my basement, a single industrial sump pump is amazing.
Yeah.
That's your 0.60 to 0.89 range. The pump matches the volume of the hazard.
Right.
But if a local dam breaks and a literal river is rushing through my foundation, an EAA of 0.90 or higher, that exact same pump is mathematically useless. It'll get overwhelmed in seconds.
That's a great analogy. If the patient has a 40 microgram burden and your cartridge can only bind 12, you're leaving 28 micrograms circulating in their plasma. And that is still vastly more than enough to maintain a lethal cytokine storm.
You'd just be wasting time on a therapy that can't possibly work. So let's talk about the hardware itself. The weapon they used is the polymyxin PMX-20R cartridge. It's a haemoadsorption circuit.
Right, an extracorporeal hemoperfusion device.
Let's walk through the bedside reality of this for the clinician listening. Because adding an extracorporeal circuit to a crashing, vasopressor-dependent patient is terrifying.
Oh, it's an incredibly heavy lift. You need large-bore central venous access, like a thick dialysis catheter in the jugular or femoral vein. Then you pump the blood out of the body through this circuit at a high flow rate, specifically 80 to 120 milliliters per minute.
Pulling 80 to 120 milliliters out of a patient every minute when their blood pressure is already scraping the floor.
It's a hemodynamic high-wire act. That's why the protocol mandated they had to achieve a mean arterial pressure of at least 65 millimeters of mercury with vasopressors before starting. If they're in profound, unresuscitatable shock, hooking them up will cause a fatal cardiovascular collapse.
And how long do they run it?
2 90-minute sessions, spaced approximately 22 hours apart. Plus, you have to run heparin through the circuit so the whole thing doesn't clot off, which obviously adds bleeding risks.
And what's actually inside this cartridge? It's polymyxin B, right?
Yes, a very old antibiotic from the 1940s. It has this incredibly high chemical affinity for endotoxin. It's basically a biological magnet for it.
But if you just give liquid polymyxin B in an IV,
You'll destroy their kidneys and the nervous system. It is profoundly toxic systemically.
So how do they get away with using it here?
The brilliance is in the immobilization technology. They covalently bound the toxic polymyxin B molecules directly to polystyrene fibers inside the plastic cartridge. The drug is permanently locked in place.
So it's like molecular flypaper. The blood washes over it, the endotoxin gets stuck to the walls of the cartridge, and the clean blood goes back into the patient. The toxic drug never actually enters their body.
Exactly. All the neutralizing power and none of this systemic toxicity.
Okay, so the mechanism is elegant. It makes perfect biological sense. But this brings up the obvious question. Why is it taking until the mid-2020s to prove this works? Let's talk about the trial lineage, the ghosts of trials past.
Right, because sepsis trials are famously known as the graveyard of critical care research. This all started with the EUPHRATES trial in Italy around 2009.
And EUPHRATES was stopped early, wasn't it?
It was stopped early for overwhelming efficacy. They showed a massive 21% absolute reduction in mortality.
But stopping a trial early for benefit is statistically so dangerous, you might just be catching a random lucky streak in the data.
Exactly, and that skepticism was totally validated when subsequent trials, like the Abdomix trial in France, came out negative or highly mixed.
So the community demanded a definitive, massive North American trial. Enter EUPHRATES.
Right. EUPHRATES was supposed to be the final word. Hundreds of complex septic shock patients, using the EAA to screen, using the polymyxin B protocol.
And it failed. The survival curves were identical. Millions of dollars, years of work, zero overall benefit.
But the researchers did a post hoc analysis. They went back into the data to see if a specific subgroup actually benefited.
And as a clinician, my alarm bells immediately go off when I hear post hoc analysis. It's the Texas sharpshooter fallacy. You shoot randomly at a barn, find a cluster of bullet holes, paint a bullseye around them, and call yourself a sniper. If you chop data up enough ways, you'll always find a positive subgroup by pure random chance.
And you should be skeptical. Post hoc analyses are usually just hypothesis generating. But in EUPHRATES, they didn't just find a random demographic cluster. They found a biological fingerprint that perfectly matched the device's physical limitations.
What was the specific subgroup?
They found 179 patients who had two strict characteristics. First, severe organ failure, defined by a multiple organ dysfunction score, or MODS, strictly greater than 9. And second, their EAA levels were exactly between 0.60 and 0.89.
The Goldilocks zone.
Right. And in that specific group, there was an absolute risk reduction in 28-day mortality of 10.7%.
A 10.7% reduction is massive. So why did the overall trial fail?
Because in the main EUPHRATES trial, they inadvertently enrolled a huge number of patients with an EAA of 0.95 or even over 1.0.
Ah. They plugged the sump pump in after the dam broke. The 12-microgram filter was instantly saturated, those patients died, and their deaths mathematically masked the lives being saved in the treatable range.
Exactly. And that realization is the entire genesis of the Tigris trial. Tigris was designed explicitly to prospectively validate that exact EUPHRATES subgroup. It was a highly specific trap just for patients with an MODS greater than 9 and an EAA of 0.60 to 0.89.
Okay, but if you narrow the inclusion criteria that much, how hard is it to actually find these people? Because the screening reality of Tigris is just staggering.
It really is. They screened 14,890 patients across 19 U.S. hospitals over 5.5 years.
Almost 15,000 crashing patients.
Yeah.
And how many did they actually enroll?
157.
157.
Yeah.
That is roughly 1% of the screened population. Let me just pause here and put on my bedside clinician hat. If I have to demand that my exhausted ICU nurses and residents screen 100 dying patients running expensive EAA tests just to find the one patient who qualifies, is that even feasible? Are we asking too much of the frontline staff?
It's a completely fair question. It's the defining hurdle of precision medicine. But you have to look at the fate of that 1% if you don't find them. These were profoundly sick patients. Their baseline Apache 2 scores were around 32.
And for those listening who don't calculate Apache 2 daily, a score of 32 usually correlates to an expected mortality rate well past 70%. These patients are dying.
Right, and 92% of them were on massive vasopressor doses, norepinephrine, greater than 0.1 micrograms per kilogram per minute. For that 1%, their baseline risk of death without the filter is over 45%. If you can save them, then relentless screening just becomes the new standard of care.
Like how we screen thousands of chest pain patients in the ED with EKGs just to find the tiny fraction having a widowmaker STEMI who need the cath lab?
Exactly. Sepsis has just never had a cath lab intervention until now. But this rarity created a huge problem. You can't run a traditional massive randomized trial if you only find one eligible patient out of every 100. It would take decades and hundreds of millions of dollars.
Which leads us to the Bayesian elephant in the room. This trial's statistical design is fiercely debated. We need to break down Bayesian versus frequentist statistics.
Sure, so most medical research uses frequentist statistics, p-values, confidence intervals. Frequentist math demands that you start every trial from a position of absolute ignorance, a blank slate.
Right. If I hand you a coin and tell you it's rigged to land on heads 90% of the time, in a frequentist framework, you have to completely ignore what I just told you. You have to flip it 100 times and prove it from scratch to get your p-value.
Exactly. It ignores all prior biological knowledge. But Bayesian statistics operates much closer to how a physician actually thinks. It allows you to start with a mathematical prior, a baseline belief based on existing high-quality evidence. You then take the fresh data from your new trial and use it to update that prior belief, generating a final conclusion called the posterior probability.
In the coin analogy, you'd say, my prior is that this coin is rigged. Now I'll flip it 20 times, and if it lands on heads 18 times, that fresh data updates and confirms my prior, so I don't need to flip it 1,000 times.
Perfectly stated. And because Tigris used the exact same criteria and protocol as the successful EUPHRATES subgroup, the statisticians and the FDA agreed they could borrow strength from that past data. They built the prior using the 179 patients from the EUPHRATES subgroup.
Okay, I have to play devil's advocate here. I've heard critics say this is just statistical money laundering. Are we just recycling old data from a failed trial to get a win because we couldn't enroll enough new patients? Aren't we cheating by bringing our past homework to the final exam?
It's the most common critique, but the authors defend this rigorously. First, this wasn't done after the fact. The FDA required the entire Bayesian architecture to be pre-specified and locked in before a single patient was enrolled in Tigris. You can't data dredge if the algorithm is blind to the future results.
Okay, that's fair. But did they just dump the old data in at 100% value?
No, and that's the key safety mechanism. They applied a 75% mathematical weight to the EUPHRATES data. They actively discounted the historical evidence by 25% to account for any uncertainty or shifts in general ICU care over the years.
So let's visualize this triplot concept they show in the paper. We've got 3 curves.
Right. The blue curve represents the prior, what we believed before Tigris, based on the discounted EUPHRATES data. It shows a benefit, but it's a bit wide and uncertain.
Then the green curve is the fresh, isolated data from the 157 patients in Tigris, completely on its own.
And the red curve is the posterior, the final conclusion when you blend the blue prior and the green new data together. And that red curve is incredibly tall, narrow, and undeniably sitting in the zone of clinical benefit.
But what if that blue prior was just too optimistic and poisoned the well?
They tested for that exact vulnerability. They ran a sensitivity analysis using an uninformative prior. Essentially, they set the prior to 0, acting like EUPHRATES never happened, and forced the Tigris data to stand completely on its own.
And what happened?
Even then, the fresh Tigris data showed a greater than 98% probability of clinical benefit for 90-day mortality. The new data didn't just lean on the old data, it independently confirmed it.
That's pretty compelling.
Plus, in standard frequentist trials, we accept a 5% type 1 error rate, a false positive rate. The Bayesian models here calculated the error rate at approximately 0.7%. It was actually a far more punishing standard.
All right, so the statistical foundation holds up. Let's unveil the actual results. What happened to these patients? Let's start with 28-day mortality.
In the standard of care group, 45% of the patients were dead by day 28.
And in the treatment group?
39%.
39 versus 45%.
Right. The adjusted odds ratio was 0.67, and the posterior probability of benefit was 95.3%.
So let's add some clinical meaning to that. The number needed to treat, the NNT, at 28 days is roughly 9.7. You have to aggressively screen and filter about 10 patients to save 1 life at the end of the first month, which is a victory in sepsis, but maybe not quite enough to convince every administrator to buy the hardware.
But you have to look at the 90-day mortality data. The signal gets so much stronger.
Normally, early interventions look great at day 28, but by day 90, the curves converge because the patients just die of secondary infections anyway. But Tigris went the other way.
Completely the other way. At 90 days, the posterior probability of benefit was 99.4%. The odds ratio dropped to 0.54.
And the number needed to treat?
6.5. You only need to treat 6.5 patients to save a life at 90 days.
Wait, why does a filter used for 4 hours on day 1 work better at saving a life 3 months later?
The authors highlighted this fascinating insight. Look at the patients who survived to day 28, but were still trapped in the ICU, the chronically critically ill.
Right, the patients with trachs, on chronic dialysis, just lingering.
In the standard care group, only 17% of those day 28 survivors made it to day 90. It was practically a death sentence. But in the polymyxin B group, 67% of them survived to day 90.
Wow. 17% versus 67%. Biologically, what explains that?
It's all about immunocuralysis. When that massive endotoxin spike hits on day 1, it triggers SIRS systemic inflammatory response syndrome. But the sheer violence of that response exhausts the immune system, leading to CAR's compensatory anti-inflammatory response syndrome.
The pendulum swings the other way.
Exactly. The white blood cells are depleted, so 2 weeks later, a mild bacteria colonizes their vent tube, they mount zero immune response, and they die of a secondary infection.
But by physically extracting the endotoxin spike early, you protect the immune system from that catastrophic exhaustion.
Right.
You change their whole biological trajectory so they can actually fight off the secondary hits in month 2.
That's the leading physiological theory. It's remarkable.
But what about safety? Pulling blood through an artificial circuit in a highly unstable patient has to have risks.
It does. They saw serious adverse events in roughly 30% of the polymyxin B group versus 22% in the control group.
So a higher raw rate.
Yes, but the safety board determined that only about 2% of those events were actually treatment-related, like one bleeding complication from the catheter placement and one episode of profound hypotension during the circuit run.
And both of those patients survived and
Yeah.
were discharged, right?
Yes, and crucially, there was absolutely zero systemic toxicity from the polymyxin B drug itself. The immobilization worked perfectly.
Okay, so we have positive data, a plausible mechanism, an acceptable safety profile. But let's bring this to Monday morning. I want to give you a clinical vignette.
Let's do it.
You're covering the ICU. You get a 62-year-old male with severe abdominal sepsis for, say, a perforated bowel. His norepinephrine is climbing. Currently, it's 0.1 Kingler, 5 micrograms per kilogram per minute. His SOFA score is 13. You run the EAA test, and it comes back at 0.74. Do you treat or not?
Based on this trial, he is the absolute perfect bullseye for this therapy. He has the prognostic enrichment, the high SOFA score and vasopressor need, meaning he's going to die without intervention, and he has the predictive enrichment.
His EAA is 0.74, right in the treatable 0.60 to 0.89 window.
Exactly. I would absolutely initiate the protocol.
But let's talk about the logistical realities of actually doing that.
Yeah.
Because you need the EAA test readily available.
That's the huge hurdle. Most community hospitals don't have the proprietary chemiluminescence analyzer for the EAA, and even if they do, what's the turnaround time?
Right, if it takes 24 hours to process, the patient is already stabilized or dead.
You need a rapid response lab workflow. You need your continuous renal replacement therapy, your CRRT machine ready to go. You need nurses trained on the extracorporeal circuit. It's a massive workflow challenge for an investigational device.
Which perfectly transitions us into the limitations of the study. We have to unpack these before anyone declares this the universal standard of care. First, it was open label.
Yes. The doctors and nurses knew who was getting the filter.
And critics will say that introduces immense subconscious bias. Why not run a sham circuit to blind the trial?
Because you ethically cannot place a massive central line into a crashing patient, pull their blood out into an empty plastic tube, and expose them to all the clotting and bleeding risks with zero potential therapeutic benefit. IOBs won't allow it.
True, but in an open-label trial, do the doctors subconsciously try a little harder for the experimental group? Do they wait an extra day before withdrawing life support? That subtle bias can move 90-day survival curves.
It's an unavoidable limitation. Another is the modest sample size, 157 prospective patients.
Even with the Bayesian prior, it's what, around 336 patients total driving this massive conclusion.
Right. In cardiology, we demand trials of 10,000 patients before changing guidelines.
But again, the 1% screening reality makes a 10,000 patient trial physically impossible.
We also have to acknowledge the industry funding. Spectral Medical funded the study and owns the rights to the device.
Which is standard for device trials, but requires us to read the statistical appendices carefully. But I think the most dangerous limitation here is the temptation of overgeneralizing the narrow endotype.
Oh, absolutely.
Imagine you have a 30-year-old patient dying of septic shock. Her EAA comes back at 0.95. Her family is begging you to do something. You have the filter in the supply room. The human temptation to just hook her up to see if it helps is going to be massive.
And you cannot do it. The data strictly warns us. At 0.95, Her endotoxin burden will instantly saturate the cartridge. It will be completely useless biologically, but you'll still subject her failing heart to the hemodynamic stress of the circuit. You have to trust the math over desperation.
So stepping back, would you use this if it gets full FDA approval?
If I had the right patient in that exact treatable window, yes. I think the Bayesian design, especially how it held up without the prior, gives me enough statistical confidence.
It really feels like we are finally seeing true precision sepsis care.
All right, that was a fun one, and maybe the closest we've gotten to precision sepsis therapy.
Agreed. As always, this is for education only, not medical advice, and meant to support, not replace, clinical judgment.
And if we mispronounced anything,
Blame the ICU brain.
or the AI voices.
Thanks for listening to PRISM Rounds.